my pleasure to be your host today. Before we get underway, I would like to first acknowledge and pay my respects to the traditional owners of the many lands on which we meet and recognise their continuing connection to land, water and culture. I'm currently on the lands of the Ngunnawal people and pay my respects to the elders past, present and emerging. We are set for a very stimulating discussion this evening, and I'm sure it will inspire some questions. We will have a dedicated Q&A session after we've heard from the speakers, but please feel free to ask your questions as they occur to you via the Q&A function you'll find at the bottom of your screen. The COVID-19 pandemic continues to exert an extraordinary and pervasive impact on societies, economies and health systems across the world. Its direct morbidity and mortality impact marches onwards. As of today, there have been over 474 million cases and more than 6 million deaths due to COVID worldwide. Health services planning for COVID-19 has understandably focused on mortality, hospital admissions and intensive care capacity, alongside vaccination and public health control measures. However, concerns about the long-term consequences of the pandemic must now also turn to the long-term clinical sequelae being seen in survivors of COVID-19. Although long COVID is not fully understood yet, it has already placed a significant burden on countries which have suffered more acutely from the pandemic than Australia. As the country has reopened and mandates rolled back, long COVID caseloads here have also risen, and the health system should be preparing to address them. Tonight we are lucky enough to hear about long COVID from 4 experts in this field. Dr. Itsik Levy will be discussing the hospital experience of long COVID in Israel. Dr. Gail Allsop, who has kindly pre-recorded a discussion of the primary care experience of long COVID in the UK. Professor Martin Henscher, who will examine the likely burden and health system impacts of long COVID and post-COVID illness in Australia. And last but not least, Professor Mark Morgan, who will talk to us about the development of Australian evidence-based clinical guidelines for long COVID. But first, I'd like to introduce Mr. Ron Gerstenfeld, Deputy Chief of Mission at the Israeli Embassy here in Canberra, who would like to say a few brief words.
Thank you very much, Rebecca. It's a real pleasure for us, the Embassy and the Government of Israel, to associate once again with the Australia Healthcare and Hospital Association for this very, very important issue that we discuss, that we're about to discuss and hear from the expert. A great opportunity to collaborate again with Sheba Hospital, with your organization, with the University of Tasmania and many more. Hospital, and we're going to talk about just very important. Israel has recently this week in Israel, you know, it's become some sort of I would say even a joke, although it's a very serious situation, that everybody that say that already had COVID in Israel, so many already were infected, that say that I'm feeling tired, so everybody says, oh, it's probably a long COVID. And it's make us a little bit philosophical and say, what are the outcomes, future outcome of the situation, whether it really exists, and we'll hear from the expert, and what does it mean? I mean, what does it mean for the productivity of humankind, for the future, recent and long future? What does it mean to the ability to those people who are infected and suffering from long COVID to be able to create, to share knowledge, and even to do basic things? And it's very interesting to know, because we tend to forget sometimes with the lifting of restriction, and we are still in the middle of the pandemic, but the long outcomes are yet to come. And hopefully with the knowledge that we heard from our experts in Israel and Australia, we'll be able to give some sort of a window to the future. So thank you very much for the opportunity again, and very successful webinar. Thank you.
Thank you, Ron. Our first speaker this evening is Dr. Itsik Levy. He's the Director of HIV, AIDS and Infectious Diseases Outpatient Clinic at the Sheba Medical Center in Israel, and he'll be talking to us about the hospital experience of long COVID in Israel. Thanks, Itsik.
Just a moment. Here it is. So thank you very much, Rebecca. And I would like first to thank the organizing committee and you, Rebecca, personally for the opportunity to present this talk this evening. It is really a great honor for me, talking to you here from Israel. I believe that this introductory slide tells the whole story. No doubt that long COVID is really a severe disease for many patients, which interrupts severely with their life, and is in other unexplained situations in medicine, the medical system treats it like a hot potato, which means everybody thinks that this problem should be treated by another one, by somebody else. So a little bit about our center, the place where I work. Actually, we are the biggest tertiary academic center in the country. We were established in 1948, and we include 1,800 beds in all three hospitals that are included in the center, which is the General Hospital, the Rehabilitation Hospital, and the Pediatric Hospital. I'm also proud to say that we were chosen to be one of the 10 leading hospitals for 4 years in a row. So no wonder that when the corona pandemic entered Israel, and it happened on February 2020, we were the first to build the Corona Center. First, it was intense. I still remember the first tent, which the first wind came and the tent just went away. We had to rebuild it from the beginning. But soon thereafter, we really learned how to build good tents. And within a short time, we converted the main parking lot into an excellent Corona intensive care unit, in addition to many other departments that were devoted for COVID patients. A few months later, we started to see really strange things. And I must say that I was assigned, usually my work, as Rebecca said, is with HIV patients, with STDs. But of course, when Corona started, every one of us got a new task. And we opened a WhatsApp group for the healthcare workers which suffered Corona. But soon many other patients, like their family, came into the group, and they were asking us questions, and we were a group of physicians, of nurses that could help them. And I must say that in the beginning, most of the questions were about the acute phase of the disease. It's understandable. But a few months later, we started to see a really strange thing in patients that suffered COVID before and actually were recovered. Here are some examples. The first two cases were patients who ran the Tel Aviv Marathon, which happened on February 2020. And now, just 3 months later, they were not able to walk even for a few hundred meters without stopping because of fatigue and for catching their breath. It was really not understandable. Of course, we did all the studies, chest x-ray, a lung function test, the saturation, and everything was normal. The only thing that we may have seen some abnormality was in the 6 minutes gait test, that we didn't see that the pulse is increasing as we would expect, but we didn't know what to do with it. Another two examples were patients, one was a teacher and the other one was a lawyer. And believe me, I tell you, their baseline memory concentration abilities were fantastic. And now they came with those symptoms, which now we call it foggy head. And one of the things we did was the MOCA test, and which is the Montreal Cognitive Test. And you can see here, even if you don't know how to interpret it, that it was not okay. You can see here the patient is asked to copy this cube, and you see that he did it very wrong. And here he's asked to draw a clock, which shows the time, which is 10 minutes to 2. And you can see that they were not able to do it. So really, we were puzzled. We didn't know what to do with this. And we saw that at this point, we started to understand something about what's happening in the acute phase of COVID, pre-symptoms, after symptoms, the immunological phase, etc. But we were in the complete darkness and about what's going on after recovery. And this is one of the sentences my boss used to say in the beginning of the corona, and I think we will use it for many years now. We learned a lot, we know a lot, but actually we know nothing. So this is Professor Galia Rav's, which was my boss' sentence. So what are physicians doing when they don't know? We opened our post-acute COVID clinic. Actually, this was the first post-acute COVID clinic in Israel. And we started the clinical study. That was on May 2020. The definition we used was actually like the definition that was accepted later. And we did not conclude, which is just to remind, I don't know if all the audience knows the definitions. When we say acute COVID, we mean signs and symptoms which are related to the acute phase up to 4 weeks. Then ongoing or persistent symptomatic COVID is the signs and symptoms occurring from the 4 to 12 weeks. And then the post-COVID syndrome, which is in our interest this evening, is signs and symptoms that develop during or after infection, continue for more than 12 weeks, and are not explained by an alternative diagnosis. We did not include in our clinic nor in our study patients with severe respiratory or systemic disease during the acute phase, like ventilated or patients on ECMO, because we believe they have complications which are related to ventilation and ECMO, etc. And we also did not include patients with PIMS and like syndromes. So after the first 200 patients, we stopped. And we wanted to see what we are learning. And what we learned from the first 200 patients is actually what we found later in a much larger population and in numerous studies that were now all over the medical literature. And we learned that severe fatigue, memory impairment, difficulty in going back to baseline physical activity, and depression were the most common symptoms. And that being female, if we look here at the multivariate analysis of risk factors, we learned that being female and the number of symptoms in the acute disease, it's interesting because it's not the severity, but the numbers were the highest risk factors for long COVID. Then after 1 more month, the Minister of Social Affairs invited us for a meeting, and he asked us several questions. Is this syndrome real? You know, people were getting really hard to believe that this is something real, because if you don't find something in the chest x-ray, in the echocardiogram, it's very difficult for people to convince that the patient is really suffering. And you know, the patients were telling us, don't call us recovered patients, because we did not recover. Actually, we are symptomatic. And the minister asked us, is it anything like chronic fatigue syndrome, fibromyalgia? What is the rate? How long does it take to rehab and go back to work? What resources should I put or allocate for diagnosis and medical treatment, for rehabilitation, for assured income? You know, patients were stopping, could not go back to work. So we didn't know those answers at that time. We didn't know how long will it continue. We did not know what is the pattern, because in the first 200 patients, we see some different patterns, and we could predict nothing. So let's start focusing in the questions. Is it real? We can say about a disease that it's real if there is a sound biological base, because then, you know, you will see the biology, you see the basic science, you can connect it with symptoms. Of course, no one will tell you it's not real. If there is a proof of concept, if there are other diseases like this that you can learn from them, or if there is an epidemiological correlation, so it's not sure, you know, like a biological base, but it's quite good. We do a lot of case control study, of retrospective studies to see correlations in other diseases also. And if it appears the same way in remote and different geographical or cultural areas, I think we can also say that it's real, or we suspect it's real. So let's concentrate now on the first question: is there a sound biological background? So definitely we believe there is. But I must tell you that all the departments in our center, pulmonologists, cardiologists, neurologists, pathologists, etc., and of course in many hundreds of places in the world were beginning clinical trials. I looked before this meeting in the PubMed, and I saw hundreds of studies trying to explain biological background for long COVID. But I must tell you that now, after looking, this is our pulmonologist work, which actually found nothing specific for long COVID. This is our cardiologist work, which the same. They did MRI of the heart. They did, of course, echo and exercise, and they could not find nothing. We did for hundreds of patients the cardiac pulmonary stress test, and we found very conflicting data. So if you ask me if there is a sound biological background, I'm sure there is, probably yes, but we could not find it up to now. And this is for one of the scientific journals, and it was written just 1 week ago. Listen, scientists have proposed many explanations for long COVID, but several I spoke to agreed that there are now 2 leading theories: that symptoms are driven by the immune system or by the persistence of the virus in the body. Importantly, those aren't mutually exclusive, and it's likely that both factors are at play and interconnected together with a number of other mechanisms. But you know what? I could tell you the same sentence 2 years ago, and actually it doesn't learn me anything. So we learned a lot, we know a lot, we know how the heart looks, we know what's happening to the lungs, but actually we know nothing. So then we asked ourselves, is there a proof of concept? I believe yes, because we see some close diseases after many other infectious diseases, like after influenza, we see the post-viral fatigue, after infectious mononucleosis, especially CMV, we see the post-viral fatigue, which may continue even for 6 months or so. We see it after polio, after HIV, where we still don't understand completely what causes the HIV-associated foggy head, after Lyme disease, etc., etc. So I think that proof of concept there is. Is there an epidemiological context? Does it appear the same way in different geographical areas and clusters? Definitely so. And there are so many studies now to show, and it's about the same percentage in different places in the world. And but is it really definitely? I love this slide of the supple English health authorities, which examined a lot of epidemiological data and ranked them at the best as very low certainty of evidence. And I must say that most of the studies, including our studies, which try to look at the epidemiology of long COVID, are really lousy because it is almost impossible to do a good epidemiological study. You need a lot of resources, which at least here in Israel were diverted to the acute COVID and immunization. And so there is no, up to now, any good epidemiological study about long COVID. So I don't have answered this. Like to try and give some answer, like colleagues in other places in the world, we try to do another study using an immediate messaging system, but the response, we send a message for almost 2,000, more than 2,000 patients, but unfortunately, the response rate was relatively low, and the real problem is it was very biased. Who answered us? The patient which had symptoms. Those without symptoms, they did not bother even to answer us. And this is actually the bias that we see in most of the epidemiological studies, even in the best places in the world. Anyway, here you can see some epidemiological data. and again, symptoms in the acute phase. But I think that the important data that we received from those who answered was that 9 months after the acute phase, 20% of the patients still have long COVID symptoms, and I'm talking from those who had the long COVID in the beginning. So it's not going anyway after 9 months. Here you can see again that fatigue, exercise intolerance, memory were the most common complaints. And again, female, gender, and symptomatic COVID were the most common risk factors. So at this time, we started to look at long COVID actually as a deconditioning state. And we tried to start and build some recommendations. Our first recommendations were to rule out other unexpected diagnoses. This should be done, I believe, by primary care physicians and as needed by specialists according to complaint. It's very sad to say that among our patients, we found 2 patients with Yaakov-Creutzfeldt disease, which were misdiagnosed as long COVID, a lot of patients with hypothyroidism. So it's important to do a good physical history taking and physical examination. It's very important to give symptomatic relief and reassurance. If there is something which I found that helps those patients to reassure that 80% of them will recover within 6 months, that they are not alone, that it's normal to feel like this. And what we really understand is that what is really needed is a multidisciplinary rehabilitation approach. So we opened the rehabilitation center, actually a very big center with physiotherapists, physical trainers for those who cannot go back to physical activity, occupational therapists, etc., for those patients with foggy head. And we are collecting now the data, and I hope that in a few months we can give the results. Now, if you look the consensus recommendations that were given in England, they give you some very important recommendations, like discuss the person's experience of the symptoms and how their life and activities have been affected, including work, education, mobility, independence, etc. Offer testing investigation tailored to people's signs and symptoms to rule out acute or life-threatening complication, etc. I must tell you that those recommendations, I think I recommend for my patients for 30 years in any kind of chronic disease. So I think that we can learn a lot from what we are doing with other patients with chronic disease.
Recording in progress.
With other patients with chronic disease, and adapt it into COVID. So I wish I would know more today, and of course more tomorrow, but unfortunately, probably after learning a lot, knowing much more, I don't know if a lot, but much more, I still know nothing or almost nothing about what's making this diagnosis, this disease. How long will it take? Will it be the same after the Omicron, or will it be, or maybe we'll see a decrease in it? And believe after the Delta wave, we believe that we are starting to see a decrease. But what happened is that now 2 months, 3 months after the Omicron, we started to see a new wave of long COVID. So I believe that like we see now the 5th wave of COVID in Israel, we also see the long COVID in waves, that now we are going to see the new wave of the after Omicron. I would like to thank you for your attention and all the members of our team, and of course the patients. So thank you very much.
Thank you, Itsik. Our next speaker has sent through a presentation from the UK, Dr. Gail Allsop. She is the clinical lead for clinical policy at the Royal College of General Practitioners, and she's going to talk about long COVID and primary care in the UK.
of the Royal College of General Practitioners in the Royal. My name is Gail Sop. I am a GP from England. I see patients face to face, but I also work as the clinical lead for clinical policy of the Royal College of General Practitioners in the UK. And it's really important, as well as working clinically and with the Royal College of GPs, I've also recently been appointed as the interim Chief Medical Officer for NICE, the National Institute for Health and Care Excellence. But today I'm speaking very much from a GP perspective and from the Royal College of GPs perspective particularly. So I started to ask my colleagues, and there were multiple stories of the same thing. And I looked at the BMJ, and there was a blog from somebody who had said as well they'd had COVID and not recovered. So I did a survey of GPs through my Royal College role and found that 2/3 of GPs had seen this. And only about 7% had the diagnostics that they needed, access to things like echoes and CT scans to rule out other diagnosis. By this point, there were some post-COVID clinics being set up in the UK, but mainly for people who'd been hospitalised and were then being discharged to follow them up, because of course we needed to collect data. And about a quarter of clinicians had access to a post-COVID clinic, but only if secondary care had referred into them. And when we asked our general practice colleagues what were the persisting symptoms that they were seeing, this is what we came up with. And we now know this list is very typical of post-COVID syndrome or long COVID. Fatigue being the biggest part, but respiratory, shortness of breath, cardiovascular, neurological, psychiatric, whether that's brain fog or depression or an adjustment type symptom, but also the fever, gastroenteritis, pain, rashes, all the stuff that we didn't really understand at this point in time. And of course, this needed a huge holistic view. We needed to look at every system in the body for these patients, not just the respiratory side, which we thought perhaps this was the cause of. And 80% of our GPs who we asked said they needed some clinical guidance on this. And also there was no way of coding any of this in our notes. And without the coding, we didn't really know how much of a problem this was in primary care. So at the Royal College of GPs, we came together and we wrote some very early guidance for our GPs, talking about what people should do. And we started to talk to lots of other partners. We started to talk to the government to lobby for people to write a guideline. We asked NICE and SIGN if they were going to write a guideline. We talked to academics who were studying this. We talked to the digital teams to look at coding. And there was also a digital rehabilitation service that had been set up in Leicestershire, which were for patients who'd been discharged from hospital to give them some ongoing support as they'd been discharged from your COVID recovery. And we started to talk to all these people just to really realise that there was a lot of work going on, but no coordination. And when we've managed to find some funding for the clinical guidelines, we as a Royal College, because we were so central and so integral to what was going on with the long COVID work, agreed to partner with both NICE and with SIGN to write the first ever guideline on what we now know as long COVID or post-COVID syndrome. Since we started to write this, we have realised how many people have become involved. And over the last 2 years since I've been involved in long COVID or post-COVID syndrome work, the number of partners we've worked with has really just exploded, from our rehabilitation partners to even things like the Scottish Royal Ballet, who are doing rehabilitation programmes, but the Department of Health and Social Care, the House of Lords, the WHO, all sorts of people. It's been really, really fascinating to watch this disease emerge. So the top tips that we wrote at the beginning for our GPs really talked about believing this is a real condition. We heard huge amounts from patients saying they weren't being believed. What we also said was that anybody with an acute infection can go on to develop long-term symptoms, and they didn't need a positive test because, of course, there wasn't testing at that point, and they didn't need to have been admitted to hospital. And that was really important because we were seeing huge numbers in the community who had this condition. Remembering it's a multi-system disease, a lot of people saying that they'd been told it was anxiety or psychological, and that a full history and appropriate examination was required to understand that impact. And that investigations were needed, so excluding underlying pathology to make sure we weren't missing a pulmonary embolus or a lung cancer as a reason for their shortness of breath, and that if people needed referring, we needed to refer them on. That guideline was used for a few months until the rapid guideline managing the long-term effects of COVID-19 was published in December 2020. And as I said, this was a collaborative effort from NICE, the Royal College of GPs, and signed the Scottish Intercollegiate Guideline Network. And as part of this, we also created a definition, looking at all the evidence, listening to all of our key stakeholders. And what we realised is that acute COVID-19, looking at all of the evidence and all of the figures, really could take up to about 4 weeks. And at this point in time, the mantra from our leaders in the UK was saying, actually, most people got over COVID within 2 weeks. And indeed, probably most people did, but there was a significant number that took up to 4 weeks. So we had this diagnosis of acute COVID from 0 to 4 weeks. Takes time to recover, possibly still infective at that point. We then added this interim group, because what we were realizing from the numbers is that most people were getting better by about 12 weeks. And if we think about other viral infections, and particularly pneumonias, the vast majority of people by 3 months will be better, and certainly by 6 months will be recovered. So we needed to think about this natural resolution, and we called this ongoing symptomatic COVID-19 because there was something still going on that may or may not get better. It also gave us time to rule out those alternative diagnoses. And then if people had symptoms after 12 weeks, this was called post-COVID syndrome. And the diagnosis of this was signs and symptoms that developed during or following an infection consistent with COVID-19, but weren't explained by an alternative diagnosis. So if we found cancer, that wasn't, they weren't fatigued because of post-COVID syndrome. These things coexisted. It was very clear that it was presenting with clusters of symptoms, and often they overlap. So we realised that there were the respiratory symptoms, but there were the fatigue symptoms. There were also the symptoms that were more akin to people with allergies. So skin rashes, gastrointestinal disturbance. But sometimes these overlapped, and they changed and fluctuated over the time. And really important, any system in the body. And very, very key, and what was coming from our patient representatives at this point is you don't need a positive test, whether that's antibody or PCR test or indeed lateral flow test now for a diagnosis of this to be made. Clinical diagnosis of COVID was enough. And we also made sure, because we were hearing reports of ongoing symptoms with children, that our definition included both adults and children. In terms of the guidance, the NICE guidance really didn't say a great deal initially from what we'd put out in our interim guidance from a Royal College of GPs point of view, but was much more evidence-based and actually did have significant things that people really needed to be aware of. Listen and believe and building trust became really important, not dismissing as psychological, but using shared decision-making, making sure that the patient and the clinician worked together. And really importantly, something that perhaps we hadn't realised in the early stages of long COVID was that this potential cognitive problems during the assessment, so the brain fog, sometimes word finding differences, and so the use of validated cognitive assessment tools came in. We worked really hard before the guideline was published to actually make sure codes were available for primary and secondary care, so that when we saw somebody and were able to make a diagnosis, we could code that diagnosis, so we could start to collate the evidence and we could start to feed this into our research. But also it became apparent that the vast majority of people who were presenting with ongoing symptomatic COVID-19 or post-COVID syndrome were really the white, middle-aged, so really between sort of 25 and 45 type population, and many more females than males. So one of the things the guideline came out to say that we know vulnerable communities were much harder hit with acute COVID. So we must raise awareness in those harder to reach groups, because if they have ongoing symptoms, they may not present themselves. So proactive case finding was considered. And we shouldn't dismiss anybody. So anyone with an acute infection of COVID-19 can go on to develop those longer term symptoms. And we shouldn't be predicting who would have prolonged symptoms based on symptoms alone. So Your COVID Recovery, I thought I would point out, this is a website for everyone. It's free to access, so you can access it from Australia as well. It's funded now by the NHS, although it started, as I said, in the University of Leicester, started just for hospital discharge patients and now is for everyone, whether they were admitted to hospital or not. And there's two parts to this website. The first part is an open website. Anyone can get hold of it. And as I've said, it was updated for community patients, so is now inclusive for everyone. And the part two actually is behind what I call a paywall. You don't have to pay for it, but it's actually behind a rehabilitation team assessment. So there are dedicated services within this package, which gives online rehabilitation support in an individualized program. But people need to be seen by a rehabilitation team and have an assessment to determine which of those programs are important, and remote support is available. There are other digital services that also help with rehabilitation, because I think one of the huge things we realised is that the need for rehabilitation and support with long COVID or post-COVID syndrome is much greater than we had the workforce or the services to supply in the NHS in the UK. So this is another one. This is funded, there's research behind it. This is called Living with COVID Recovery. So please do, again, have a little look. There's an email there if you want to find out more about that. This is a service where the people that run this say that with a single physio, you can probably look after at least 100, sometimes more than that, patients per week, using one physio to oversee this, this Living with COVID Recovery. So please do contact them if you're interested. England then opened up post-COVID clinics, and the reason for this was because patients were saying they were getting referrals all over the place, multi-system disease, and the idea initially was that this was just a diagnostic clinic for investigation, a one-stop clinic where everything was looked at from mental health to physical health for adults and children. And they recognised actually that there was a gap for treatment and rehabilitation. So these services now in England have moved on to start to provide rehabilitation rather than sending back to primary care or onto other services. And the digital apps, the Living with COVID Recovery and Your COVID Recovery, is being used quite extensively, as well as traditional face-to-face rehabilitation. Other parts of the UK haven't used the post-COVID clinics. So in Scotland, they haven't, and in Wales, they haven't. Instead, they've looked towards a primary care model using secondary care, as it would do usually for more serious presentations. Northern Ireland's trying the post-COVID clinics out at the moment and is going to see how they go. But patients can be referred from anywhere effectively into a post-COVID clinic. We have huge amounts of patient information floating around, some of which is great. So the SIGN guidance and the NICE guidance, the Royal College guidance, was turned into a long COVID booklet for patients, so a patient version of the guidance. And this, I think, is fantastic. If you just Google SIGN long COVID patient booklet, you'll be able to download a copy of that. You can print it out, forward it on to your patients so that they can really understand what should happen to them in that pathway. And of course, there's lots of other patient groups. We found peer support amongst our long COVID, our post-COVID syndrome patients has been really important, incredibly useful, and some of them actually people have found that they've left because they haven't been as helpful as perhaps they'd hoped. So really important that they're monitored, and there are some fantastic international ones that I think work really well. And just in the last couple of minutes, I thought I would talk about the workforce, because of course the workforce is hugely important, not only because we're seeing huge numbers of patients coming in with problems that we need to look after, but also a lot of our workforce caught COVID-19 at work. So whether they're teachers or whether they are healthcare professionals, and actually the longer term effects of their COVID are now affecting them. So there's two things. One thing is the education. It becomes really, really important, and the Royal College of GPs have done lots and lots of educational work. So if you go to the Royal College of GP website and you put in post-COVID syndrome, or just Google post-COVID syndrome webinar Royal College of GPs, you should find our webinar reminds, you should find our e-learning, all of which again are free and open to everyone. And we run monthly interactive education networks with national and international experts for all of our GPs as well. But the complexity of this disease and the increased pressure on the workforce at the moment means that actually we need more time. So we're trying to encourage our government to provide more time for GPs, but also for the system at large to deal with long COVID. And thinking about occupational health and sick leave, because this isn't universally given across the health and social care in the UK, and we're now finding a lot of our clinicians are running out of sick leave. So the Faculty of Occupational Medicine, this is a fantastic resource, have pulled together some advice for people returning to work with long COVID or post-COVID syndrome. So again, please do Google this. It's really useful. You can use that yourselves as well. And just really to finish off by saying the latest figures from our Office of National Statistics survey show that we've got about 1.1 million people who are self-reporting to have long COVID in the UK, of which about 70,000, we think, from the self-reported survey, have had those symptoms for more than a year. So the vast majority of people are recovering, and I think that's an important thing to hold on to. But there is significant long-term sequelae that we are seeing. Please do use my email address. Again, I'm so sorry I couldn't be with you today. I hope this has been useful, and I look forward to hearing the feedback. Many thanks.
Our next speaker is Professor Martin Henscher. Martin is the Henry Baldwin Professorial Research Fellow at the Menzies Institute for Medical Research at the University of Tasmania. Thanks, Martin.
Thank you, Rebecca. Hopefully you can see my slides. And I'd just like to acknowledge the peoples of the Lutruwita nations and the Wurundjeri people of the Kulin Nation as traditional owners of the lands where we did the work that I'm going to be presenting briefly to you about. I'd also really like to acknowledge my fantastic colleagues at Deakin University and University of Tasmania, particularly Mary Angeles, who's really done a lot of the heavy lifting in this work, and I'm hoping is watching this. So very much a fantastic team effort. So I'm going to drive straight in to talking about modelling of long COVID and what we've been doing. We really got into this in working with Rebecca and colleagues doing a briefing paper for the Deeble Institute about a year ago. But long COVID clearly by then was already becoming an issue, and it seemed to me to be something that we needed to try to get ahead of. So modelling is a very important tool, not the only tool, but an important tool in trying to get to grips with uncertainty and thinking about future responses. So I'm going to talk to you about 3 different pieces of modelling we've done very briefly. There are some different elements, and these models cover slightly different things. All of them have looked at long COVID, which we don't need to define now because I think our previous speakers have done a really good job about that. One of our models also, though, looks at the burden of 2 other important sequelae of COVID, which I just think it's quite important that we don't ignore. One is post-intensive care syndrome for people who've been hospitalized in the ICU. Probably more importantly, but much more uncertainly, though, is the other kinds of permanent disability, permanent impairment, which it's sort of increasingly looking like quite small numbers, but not trivial numbers of COVID patients might go on to suffer for a long period thereafter. Now, all modelling rests on assumptions. We have to use assumptions because we're uncertain, and if we knew all the facts, it wouldn't be a model, it would be a description. But so we're trying to work with uncertainty in this modelling. So key parameters just to think about, and key assumptions that we're thinking about, is that clearly there's some relation between how many people to go on to get long COVID and the number of people, obviously, who have COVID-19 infections in the first place. But what we really don't know still is whether that relationship is changing with different variants. We really don't have the numbers yet to know, particularly after Omicron has risk changed in that. We are getting better evidence that there are some other modifiers of risk. So, for example, I think it's looking increasingly strongly like vaccination does reduce your likelihood of going on to develop long COVID. So that's some of those factors are important to think about. Big uncertainties, though, about the duration of long COVID and the trajectory of recovery. As others have said, most people who develop long COVID will recover over time, clearly. but it's still less than clear exactly what is that trajectory, precisely what are the numbers there. And lots of uncertainties about really the burden of this, what actually is the severity of long COVID, how do we measure it, etc. Some studies just in the last weeks beginning to come out with quality estimates, for example, of long COVID, a really good UK study. Too late to go into our modelling at the moment, but some of this evidence is beginning to come out now. And then finally, the key limitation in all of this is obviously about data and sources. So we have a very small number of good Australian studies. We've relied particularly on one by Betty Liu and colleagues. The gold standard really that's coming out, I think, on the largest, most robust measurements of long COVID is really by the UK Office for National Statistics. There's lots of studies of long COVID, but they're all complex. Many of them are looking at hospital cohorts. Many of them are looking at quite small numbers of patients. ONS have dived in and looked at very large numbers in the population with very big surveys. Now, where are we and where's long COVID in Australia? Well, look, until a very few months ago, there just wasn't going to be much long COVID in Australia because there simply hadn't been much COVID in Australia. And then obviously we've had Omicron, which has changed our situation completely. So our first foray into this game, which is now a year ago, where we looked at how many long COVID cases might there have been in Australia at the end of March last year, based on some very preliminary modelling. We were coming up with a few thousand, really 2,500 to 5,000 people at that stage. We might have had long COVID. That was a very simple kind of testing the waters. So then during the course of last year, we did more work focusing more on what might be the burden of disease of post-COVID sequelae. And we tried to, at that stage, still in the absence of Australian data and indeed in the absence of large outbreaks in Australia, what we tried to do was we took the Doherty modelling, the Australians in the audience will remember that, from which was the modelling that was used by National Cabinet to think about how the national reopening plan was going to work. We took that Doherty modelling, which had great work on different parameters, numbers of infections, deaths, hospitalizations, ICU, etc. And we tried to apply a Daly burden of disease model to that Doherty modelling. And making a couple of critical assumptions that I think it's really important to spell out. We've assumed in that model that most long COVID does resolve over time, as others have said, but we also in that model, we looked not just at long COVID, we did look at PICS, post-intensive care syndrome, and we also looked at some of these other permanent illnesses and disabilities that the evidence was beginning to come out from, assuming that they then might have a lifetime duration. So that's things like cardiac disease, potentially the increased risk of developing diabetes post-COVID, some neurological issues, some of these things. And we took daily weights from the literature for similar and equivalent conditions. And there's a preprint that you can find if you click through those slides. The key thing we found, and this is an important message I really want to get across, is compared to the first year of COVID in 2020, where far and away the largest contributor to the burden of disease in Australia was mortality, even as we looked at the Doherty model, and if you remember, Doherty was beginning to factor in vaccination, etc., we could see a shift of the burden of mortality beginning to decrease, and in fact, the importance of the burden of long COVID starting to go up. The burden of PICS, of post-intensive care syndrome, fell because fewer people were being admitted to intensive care units. Again, this international trend we've been seeing. However, what's critical here is once we include the possibility of permanent illness, so some of these long-term, lifelong illnesses, we see suddenly the burden of mortality gets relegated to second place. And quite quickly, even really quite small proportions of COVID cases, if they actually develop long-term illnesses, so the cardiac complications, diabetes, etc., probably the burden of that permanent illness becomes the major contributor to overall burden. And that's something we might want to come back to. So then finally, in the last couple of months, we've then tried to do some quick modeling once we actually got into the Omicron wave. So finally, we were there. Finally, the large numbers that we'd successfully dodged for 2 years caught up with us. And we tried to look at, very simply, what was this going to mean potentially for numbers of long COVID cases, not for PICS, not for permanent disability, just for long COVID. We made some very simple assumptions. We reckon we got to the peak in mid-January. So with very sophisticated epidemiological modeling, we doubled the number from the beginning of the Omicron outbreak to the end, and we were pretty close. We reckon there'd be 3.1 million cases between the end of November and the middle of January. In fact, there were just under 3.3 million. So for me, I was pretty happy with that. And then we used similar approaches with 4 different scenarios of how long COVID might play out. And in particular, we looked quite hard at the potential impact of vaccination on long COVID numbers and did some sensitivity analysis about different levels of effectiveness of vaccination on long COVID numbers. So these are our 4 methods, really, how they play out in terms of numbers here. They're probably a little small to look at, but what I really want you to focus on is 2 of these models. So the Liu et al. Model and one of the ONS approaches, ONS approach 2, start with quite high numbers of people, or high proportion of people developing long COVID, but then fall rapidly. Most of these studies actually haven't followed people for very long. The maximum period in these studies people have been followed for is up to 24 weeks. So we applied exponential decay functions to try to push these curves out over time. And what you see is that with some of the models, you end up going down to very low numbers before we get to a year. So in fact, 2 of these approaches, we were getting only potentially hundreds of, in single, 100 to 200 people with long COVID after 52 weeks, which doesn't chime with what we're seeing from other international studies. 2 of the ONS approaches, though, give us quite different results. They start with lower and more conservative proportions, but they track over time. The reduction in people with long COVID over time is much slower. And so we do end up with larger numbers of people still with long COVID at 1 year. And where we got to with this really was using these models to look at how many long COVID cases might there be 12 weeks after initial infection. So if we're thinking about the beginning of the Omicron wave, we're kind of at that point, really. We're beginning to be at that 12 weeks after Omicron stage now. I think we're probably looking at, 60,000 to 200,000 or so is our central estimate. How effective the vaccines have been is important. That makes quite a big difference. If vaccines have been very effective in preventing long COVID, we might be below 50,000 people. But if vaccines have actually proved to be not very effective, we might have hundreds of thousands. Then if we think about how many long COVID cases we might have in a year's time, a year out from their initial infection, as I said, we kind of tossed out 2 of our scenarios because those exponential decay curves got us down almost to 0 well before it was plausible. So using the other 2 scenarios, I think we're probably looking at most likely tens of thousands to maybe 100,000 or so cases still with long COVID from the Omicron wave as we've looked at it. This is saying nothing about any future waves or how, and as you could see from the COVID cases, we all know we're already going back up again. So this is just from the kind of summer Omicron wave. But I think from that wave, probably not more, I think, than 200,000 people, or less than 200,000 people, to be honest, by a year out from initial infection. Key points really I'd like you to take away those. As the mortality rate decreases, the relative burden of long COVID and of other permanent illnesses increases. And that's really important. The long COVID and permanent disability really will be what is driving the big burden of COVID going forwards. I think the kind of numbers we're talking about for long COVID in Australia after Omicron now are significant. They'll stress the system, but hopefully they're not overwhelming if they're managed well. But I think it's always possible to snatch defeat from the jaws of victory. And if we manage this badly and we're running into future waves that add more burden, actually this could, done poorly, could be a really big burden on the health system for some years to come. I'd, caveat everything I've said in the fact that our understanding of the duration of long COVID and of these other permanent illnesses is still very limited, and we need a lot more data there. So just finishing off, what do I want to see going forward? I really want to see surveillance. We've got almost no surveillance in Australia now. We must get good, high quality surveys, and we need to follow the model of what they've done with the ONS. And I'd really like to see the Australian Bureau of Statistics doing those surveys and not researchers. I'd like the ABS to be on the ground doing this stuff. And we need to really follow people up over time in detail. We need to understand the impact on their health-related quality of life, and we really need to understand employment and economic impacts. Mustn't forget prevention, because every case of COVID-19 we prevent is someone who's not going to go on to get long COVID. It's often forgotten in this, but it's really central. I think we really need to move into working on our care models and our coordination of care. We've got to mobilize the private sector for this. We can't just shunt this into the public hospital system. But if we do it well, this could actually be transformative, not only for long COVID, but actually for things like ME, chronic fatigue syndrome, people with autoimmune illnesses, people who are poorly served by a health system at the moment. And finally, we really have to ask patients what they want and need. What care do they want? What kind of support do they need? And we've really got to get them involved in leading and co-designing both the research and services going forward. Thank you very much. You're on mute, Rebecca.
You'd think after 2 years of Zoom we'd get this. Our last speaker for the evening is Professor Mark Morgan. He is co-chair of the National COVID-19 Clinical Evidence Task Force, Mild and Chronic Care Panel, and he'll be talking about the Australian evidence-based guidelines for long COVID. Thank you, Mark.
Thank you. Can I just confirm you can see my slide there? Fantastic. So I'm going to be talking a little bit about the work of the National COVID-19 Clinical Evidence Task Force, because I think this is a remarkable piece of capacity building and infrastructure building that will be critical for successful generation of long COVID guidelines as we start to understand more about this condition. So the National COVID-19 Clinical Evidence Task Force brings together 33 peak bodies and hundreds of clinicians volunteering their time with the purpose of building the structure that gives us guidelines for COVID treatment, to do this in a continuous way with a weekly update based on evidence surveillance, and to become the trusted, the source of truth for the management of COVID-19 in Australia. Important to mention the funders, because we need to know whether this is biased by funding, but Australian government, state governments and some philanthropic foundations are funding this work. So why a living guideline? We know there's been a tremendous amount of research done on COVID treatments. A couple of weeks ago, more than 600 randomized controlled trials and about 4,000 in the pipeline, hundreds of thousands of studies. I think in the first week of March, another 14 randomized controlled trials were done. And as any of you that work in the health system will know, there's a smorgasbord of confusing expensimab and yet another IB and variations of VIR treatments that's really hard to keep up with. So guidelines are important to make life easier. It needs to be a living guideline because of the rate of change of information. And the sort of output comes from this work are evidence-based, grade designed guidelines demonstrated in the MAGIC app that really give a clear, simple recommendation that defines a population, defines a treatment, and then explains whether or not there's good, strong evidence for that treatment and whether it's applicable and appropriate. And then in parallel to that are clinical flowcharts. And at the moment, we have a clinical flowchart for long COVID that's based on a collation of existing evidence, adapted and adopted, adapted for an Australian context by our expert panels. And that's the state of play at the moment is because we don't have evidence for specific treatments for long COVID yet. To give you a flavour of the size of this infrastructure building, there are over 250 clinicians involved in the task force, 13 standing expert panels, also assisted by conflict of interest panels, consumer representative panels, and leadership groups. We have 15 clinical flowcharts about different aspects of managing COVID, and over 165 treatment recommendations that are evidence-based. So in our flowchart for people with post-COVID-19, we went with a pragmatic definition, wanting to provide some guidance for clinicians to cover both ongoing symptomatic COVID-19 in that 4 to 12 week period, and also the 3 months and on or 12 weeks and on period that is defined as long COVID. So the second step of our work was to do an evidence review. And as we've heard, you can be symptomatic with post-COVID-19 if you've had mild disease, if you've had severe disease, if you're an adult, if you're a child, and there's a big variation in people's experience. And as I said, no evidence-based recommendations for particular interventions. So our expert panel and flowchart thought that, as we've heard before, that the communication with patients, taking this seriously, validating their experiences was very important. The coordination of care was important, and we focused on a primary care approach and then multidisciplinary team where available and where necessary. We thought it was important to talk about managing the risk of infection, defining whether it was probable diagnosis and searching for other conditions, as we've heard with international guidelines, and also assessing for red flags, things that need immediate treatment. We looked carefully at the sort of range of symptoms. We didn't want people with less common post-COVID symptoms to fail to access treatment and the right care. And we included in our guideline a consideration of the post-intensive care syndrome as it was important. When it comes to management, very similar to the international guidelines, we talk about basically managing long COVID in the way that we've learned to manage other post-viral conditions and uncertainty and other chronic conditions. So not specific at this point. Thank you.
Thank you, Mark, and to all our speakers. At this point, I'd like to open up the floor to questions. If you have a question, please put it into the chat function. No, so I'll start off. We know that some populations have suffered more throughout the pandemic, from being able to comply with public health measures to accessing testing, to accessing treatment. What do we know or even suspect about equity in long COVID? And the second part to that question is really, how can we support more equitable access to care? Mark, perhaps you'd like to take that one?
I'm happy to. Well, in terms of the epidemiology, there has been a lot of descriptions of the epidemiology of long COVID symptoms, not so thoroughly in Australia as in other countries. We've heard already that women are more likely to suffer with long COVID symptoms. We've also heard that the increased number of acute symptoms, and certainly for the disability and post-intensive care syndrome, the severity of your illness would make a difference as well. We also know that with all healthcare issues, if you look at social disadvantage and reduced access to care, that those communities are the ones that suffer most, and those individuals are the ones that suffer most. I think equity is going to be helped by what we've learned about online resources, and I think presentation about the work of the in the UK to make those resources available to as wide a number of people as possible is going to help. I think there is a danger if we go with a single approach of multidisciplinary clinics, because naturally they're going to sit in large teaching hospitals in urban centres, and we will increase inequity. So I think we probably need a blended primary care and multidisciplinary approach with the appropriate triaging, but probably centred on primary care, because that's the only really distributed way of delivering healthcare we have at the moment.
Thank you, Mark. We have a question that's come in from the audience. Is there any evidence yet on the difference of long COVID between Delta and Omicron? Itsik, perhaps you'd be able to answer that one?
I'll try to do my best, but you know, it's the lack of information that we have, so even the best is not that good. Actually, after Delta, we did in-depth studies. We gave the patients the SF36. We did mocha for everyone. We did a lot of in-depth studies, so we could have the exact symptoms and signs of the patients. After the Omicron, we didn't do the same because, you know, we thought we have enough information. And so actually, I really cannot tell you if after the Omicron it's the same or not. From the clinical perspective, you know, when a patient comes in and complains, I think that one of the things that we saw a lot after the Delta and the Alpha waves, the first waves, we saw the loss of smell and taste and hair loss, which we saw in many patients with long COVID, and I don't see it now with the after Omicron long COVID. I'm sure there are more difference, some of them more subtle, some of them more notable, and actually we saw that we have to do now the same study with in-depth study like we did after the first waves, so we can answer this question. So I hope I have better information in the future.
Thanks, Itsik. Our next question is around people with undiagnosed COVID, and they might be going on to develop post-COVID-19 symptoms that are being missed or misdiagnosed. What safety nets do we need to be developing for this cohort? Martin, are you able to tackle that one?
Yeah, so I think thinking about that, there's a couple of things we need to do. I think, you know, the speakers who talked about guidelines and clinical practice have quite rightly said it's essential to take really good histories from people to really work through what's going on, work them up well. But I think honestly that step one though is, given we've just had this massive outbreak and we would expect large numbers of people to be presenting with long COVID, health professionals just need to have front of mind now that long COVID is a highly likely diagnosis for people coming, coming to them with these kinds of symptoms. And I think we have to learn from other countries where it's clearly been really difficult culturally for some health professionals to get their head around this and to perhaps get out of how they were previously practicing. So there's a real, it's difficult to use the right word, but there's a real kind of communications job, I think, there with health professionals. So you don't want to assume that everybody's got long COVID, but equally it's highly likely given where we are now. So that's number one. Then I think in terms of like literal safety nets, as we talked about in that Deeble Institute brief now a year ago, but there's work to be done in Medicare and MBS on making sure we've got the right items, particularly making sure literally the MBS safety net is tuned to correctly support people who might now have long COVID and might need, quite long-lasting levels of input, and therefore it gets quite expensive. So I think we've really got to look at Medicare, and more widely for economic and welfare policy, look, we've got to look at what are the consequences of this for people's ability to earn. Coming back to the previous question about inequality, look, this quite possibly more socially and economically disadvantaged people are going to be more at risk for this, but certainly once they have long COVID, those are the people for whom this is going to bite really badly economically. And we've really got, the government, the federal government in particular, has really got to look at retooling the social safety net to work properly for people in this position.
Thanks, Martin. Mark, did you want to make a comment as well?
Look, I would agree with those points, and certainly the need to build capacity for the health system and for practitioners within the health system to provide rehabilitation, and help from a whole bunch of different professions if that's necessary. I also think it's probably not absolutely essential to diagnose people with long COVID. If they have distressing symptoms that are consistent, then at the moment, because we don't have specific long COVID treatments, we can apply the same principles for helping those people. So I would think the same system for the people that have got post-viral fatigue or just unexplained groups of symptoms should be able to access the same rehab, but we do need to grow that ability to do that rehab.
Thank you, Mark. Our next question, I think, will also be for you, Martin. It says, Tasmania seems to be lagging behind in any help for long COVID sufferers. Do you know if there's anything happening in Tasmania about this?
So my honest answer, as a fairly recent re-arrival into Tasmania, is I am not aware of, let's say, major plans in Tasmania, but that doesn't mean it's not happening, but I don't know about them. But what I'd maybe flip that around and say, look, I'd love to hear from people, particularly, and I am in touch with a couple of people in Tasmania already, but people who would like to see more action happening. I'd love to make contact and see what we can do actually about advocating for this at the state level. Yeah.
Thanks. What can be done for regional and remote populations who develop long COVID syndrome? And I'd like to add to that, Mark, without putting you on the spot, does the task force have any plans to develop guidelines specific for Aboriginal and Torres Strait Islander people?
Answering the first part first, I think we have learned it's possible to deliver allied health and medical consults remotely, and that should be facilitated and an expectation that we build more to save the burden of travel for individuals than because we can't afford to provide services in rural and remote areas. So I think we should be building that and maintaining that capacity and not putting artificial constraints around access to telehealth and video health for fear of wasting money. I can't imagine people having wasteful consults in large numbers. I think everyone's time is valuable. So I think if there's a need, we should be fulfilling that need as best we can. The second part, which was about specific populations, within the task force, we have been working on guidance for specific populations where there is evidence of a difference of approach that's needed. And we work particularly in the primary and chronic care panel. About half of the panel were people that lived and worked in remote areas as we started this journey, and so we were acutely aware. But it's really the operationalization, the implementation of clinical guidelines and treatment guidelines where how it plays out in different parts of the country comes into play. So the actual decision on whether drug A is good for COVID or not and how it should be given is sort of a little bit independent of that. And then the operationalization of it, the implementation, is where it becomes really important for each community and each part of the country.
Thanks, Mark.
I just wanted to add for the questions about also with long distance that we opened here in Sheba Connect, it's called, and actually it's a rehabilitation unit which gives you rehabilitation services digitally with trainers that you can connect with them and train at home, with occupational therapists that's done. It works fantastic. So we could really actually almost close completely the in-hospital long COVID clinic, because most of the patients preferred to do it through the digital clinic. And we have a really good experience with it.
Thanks, Itsik. The next question I'd like you all to have an attempt to answer at is, communication has been critical throughout the pandemic. What recommendations would you have for governments and health systems in terms of long COVID? And how can we anticipate messaging might need to change over the upcoming months and years? Itsik, would you like to comment on what communication has been like in Israel and how effective government has been there?
I must say that here the system works probably a little different, and actually we have 4 HMOs which cover all the population, and they are in constant connection with the government on the one side, with the hospitals on the other side. So we have a very good system which everyone can connect with everybody. So, if we need information from one of the HMOs, so they need the information for us, it's after we are doing, of course, the ethical things and everything, it's very easy to communicate between all the parties. And in our major teams, like those, combating the epidemic in the acute phase, now about the long COVID, we are sitting all together, representatives from the government, from the HMOs, and from the hospitals. But I think that it's possible because Israel is really a tiny country, with 10 million every physician knows every physician almost, so I think it's much easier to do this communication than in Australia.
Thanks, Itsik. Mark, would you like to comment?
Yes, look, at the moment, there seems to be a lot of communication, too much, and from too many different sources, and saying slightly too many different things, and particularly if you add in less reliable sources. So I actually think that communication needs to be prioritized, needs to be resourced, things need to be translated, and I actually think we should be shamelessly borrowing and stealing and adapting from places like the UK, who've put quite a lot of resources into the messaging. But the other point is that because the messages have to change, I think we need to treat the population as able to understand that. I know people want black and white, but actually at the moment we can only give information that we have, and to really kind of signpost that information will change over time, and really concentrate on making showing people where to look for reliable information.
Thank you. Martin?
Yeah, two things for me really on that communication space. I think in a carefully designed way, I think governments need to be getting the message out to people that, yeah, you don't need to have been severely ill with COVID to go on to develop long COVID. So, you know, if you're not recovering, if you're, don't suffer in silence, don't be scared to seek medical advice. I think that's a really important message to get out to the population. I think the other one, though, is we mustn't let the desire to communicate the kind of living with COVID story that we've been, or that many governments have been wanting to project. We mustn't let that interfere with doing the things we need to do to actually live with COVID. So we need to set up the surveillance systems, we need to set up the services and service models and safety nets that people are going to need actually coming out of the other side of COVID, because that's what living with COVID really is about. And we mustn't, let let's say more politicized desires contaminate what we're actually doing and the factual content of what we're communicating.
Thanks. Martin, can I direct another question at you? Given the treatment pathways recommended for long COVID, to what extent will out-of-pocket expenses be an issue for those seeking care for long COVID?
That's a great question, and the answer is, particularly if you're unlucky, they could be significant. So when I was talking about, I think we need to mobilize the resources of the private sector and coordinate with the private sector, I think this is something where we need to look now at, are there ways to come up with new models of how we finance some of this stuff, and particularly deal with this out-of-pocket payment problem, which, that's the core problem of really at the heart of much of what's wrong in the Australian health system at the moment. How can we look at that? We absolutely, as I said, we've got to make sure that the MBS safety net, those kinds of measures really are not letting these people in this position fall through the cracks. But this is a really good time to look at some different models of maybe how can we use the private sector, but start to reduce, if not perhaps eliminate, some of these out-of-pocket payments.
Thanks, Martin. Mark, do you know if there are any plans to open a post-COVID clinic nationally, and can you comment?
I actually don't know exactly how far those plans have got. I know that there are centres, mostly around the respiratory clinics, that are starting to build that expertise. But in terms of planning at a state-by-state level to open up post-COVID clinics, I don't have that information. Just going back to the previous question, if I may, Martin was talking about alternative ways to deliver, and we've heard an echo of that in the presentations. So certainly a greater use of group consultations, of peer-to-peer support, of digital resources that are not kind of one-on-one with a practitioner. Those things help, and certainly at the college we've been working with the Consumers Health Forum to try and build a social prescribing system. Social prescribing is where health practitioners refer to non-health services and connect people into non-health services. So that might be opportunities to develop skills, to rehabilitate. It doesn't need that kind of high-end, highly trained specialists. So I think there are ways and alternative models that are not as expensive as paying for a one-on-one time with a highly trained allied health provider or doctor or nurse.
Thanks, Mark. And the last question for the evening, is there any evidence of the impact of long COVID on the healthcare workforce and the impact of the capacity of the health system to provide services to the community? Martin, have you had a look at that through your work?
So I've read a fair amount about this. I would not pretend to have, reviewed systematically what the evidence on this is, but I think as I can see it, I think in other countries that have had much more severe earlier waves and hence have had big numbers of people with long COVID for longer periods, there's certainly some reason to believe that it's disproportionately affected healthcare workers. It's certainly, I think, little reason to believe that healthcare workers are less likely to be impacted by long COVID than other people. I think, will that impact on the healthcare system? Well, at an operational level, yes, depending on the numbers and really, how many people who are out of the workforce for how long is the fundamental question there. I think, though, it's kind of a multiplier because we do have this evidence both internationally and in Australia that, some healthcare professionals are leaving the health workforce for other reasons as well. So if you've got kind of a long COVID as yet another force kind of driving people out of the healthcare workforce, that's clearly not going to be a good thing.
Thank you, Martin. Just going to share my screen. So I'd like to thank all our amazing speakers for joining us today. A copy of the presentation will be made available to you shortly, but to find out more about our future events, please head to the AHHA website. Again, thank you everyone for joining us, and I look forward to seeing you again at one of our upcoming events. Thank you.
Thank you very much.
Recording stopped.